Morning, everybody. Thank you for the opportunity to speak in Athens today. I'll be talking about the risks of teenage pregnancy based on a 12-month retrospective review we performed in Shrewsbury last year. This was supervised by Dr. Oates, the consultant, and I've been helped along by one of our colleagues, Dr. Calcott, who's very good at statistics. So the UK has the highest teenage pregnancy rate amongst Europe, and despite the age of childbearing increasing, the teenage pregnancy rates have remained static, although in Shropshire our rates of teenage pregnancy has been steadily declining over the last 10 to 13 years. Among healthcare professionals and the public alike, there are perceived worst outcomes in teenage pregnancies. In the media, it's always reported shocking when the youngest teenagers become pregnant and mothers. It's in television shows where it's in America predominantly in the media. So in terms of what are worst outcomes perceived in teenagers, we all know that preterm birth is a leading cause of morbidity and mortality, and in the literature this is reported more than 3 times higher in teenagers compared with age 20 plus year olds, and that goes in developing and developed countries. Furthermore, in the literature, the rates of small for gestational age babies are higher among teenagers, but there is a debate regarding confounding reasons for this. So in terms of the study we performed, the objectives were to report on the outcomes of teenage pregnancy across our trust. For those of you that don't know, Shrewsbury and Telford covers a very rural area in Shropshire. There's a consultant unit with an attached midwifery-led unit, and then 5 other outlying midwifery-led units feed into that trust. The objectives were to compare the teenage pregnancy outcomes with the local population outcomes as a total. And then since the last talk in Leicester, we've done a sub-analysis based on the feedback we got there, comparing primiparous teenagers with the primiparous women who are aged 20 years and above. The data was a 12-month retrospective review between April 2013 and March 2014, and we used the hospital electronic database to gather the data. We classified the outcomes comparing our teenage mothers who were aged 13 to 19 years at the time of delivery versus the total population who delivered in the study period. Looking at the pregnancy outcomes, we compared maternal versus fetal outcomes. In terms of the demographics of the results, we had 264 teenage mothers deliver and a total of 4,916. The mean ages of the teenagers were 18 and the total mean was 29 years. The booking BMI was similar, there was no statistical difference there. In terms of looking at the place of delivery, the spectrum of home delivery versus midwifery-led and consultant were similar in both groups. The onset of labour, there was a higher rate of spontaneous onset of labour among our teenage pregnancies, similar rates of induction of labour in the blue, and a significantly lower rate of elective caesarean section amongst our teenagers, but generally low rates of caesarean delivery in Shropshire. This is a rather busy slide, I apologise. And it just looks at comparing on the right the teenage outcome data versus the total group outcome data of mode of delivery. And you can see that a large proportion of our population were delivered vaginally with a small proportion of caesarean sections, about half that in teenage pregnancies compared with the total group, and then a similar split of elective versus emergency section. And then if we move down to the vaginal delivery group, a high and similar proportion of spontaneous versus operative delivery, and then that was further split into forceps, ventouse or double instrument delivery. So looking at the mode of delivery in the teens, the overall risk of caesarean section was significantly lower, about half that among teenagers compared to the total population. And then taking out elective sections, the risk of emergency sections again was about half the risk in teenagers versus total. There was no significant difference among the risk of operative vaginal delivery, so teenagers were not at higher risk of operative vaginal delivery. And then in terms of the subgroups analysis, this further study that we've looked at comparing, we've just looked at primary paraswarmers. We were planning to do multips as well, which we're undergoing at the moment. But we want to compare PRIMEP teenagers versus PRIMEP 20-plus-year-olds to control for parity. And in the pink are the statistically significant results. So significantly less risk of any caesarean section, particularly emergency caesarean section. We found that among PRIMEP teenagers versus PRIMEP 20-plus-year-olds, there was a statistically significant lower risk at booking of operative vaginal delivery. And then we also looked at the risk of operative vaginal delivery after they presented in spontaneous onset of labour, and that again was lower amongst PRIMEP teenagers. The risk of sustaining any perineal tear, again, was significantly lower among teenagers, and the risk of third or fourth degree perineal tears was not statistically significant, but a trend to less risk among teenagers. And again, the risk of postpartum hemorrhage was statistically significant, half as likely among teenagers compared to 20-plus-year-olds. So looking at perineal trauma, the teenager has a higher chance of an intact perineum at delivery, and that's even more significant in the subgroup analysis. Teenagers are significantly less likely to have a postpartum hemorrhage of more than 500 mils. And then moving on to fetal outcomes, we didn't show a statistically significant risk of preterm delivery among teenagers. There was a low risk of stillbirth in the study, so we can't really comment on significance there. Risk of shoulder dystocia was similar, not significantly different, and APGAR scores were the same in both groups. There was a significant difference in the mean term birth weight, but I don't think this represents a clinically significant risk, 3.3 versus 3.4 in clinical practice. So in terms of concluding the results, what are the risks? In this study, the majority of teenage mothers were in fact aged 18 or 19 years. We didn't have any 13 or 14-year-old mothers in the group. However, over 90% of our teenagers had a vaginal delivery, and there was a significantly lower risk of operative vaginal delivery in first-time teenage mothers. And that was half as likely as the 20-plus-year-olds if they presented in spontaneous onset of labour. We had no failed operative vaginal deliveries among the teenagers, and there were significantly lower rates of caesarean section. PRIMEP teenagers were half as likely to have a caesarean section versus 20-plus, and excluding for elective caesarean sections, they were a third as likely to have an emergency caesarean section as the 20-plus counterparts. There was not a significant difference in severe perineal trauma, but there was a trend towards a lower risk among the teenagers, and more than 60% of our teenagers had an intact perineum at vaginal delivery. There was a significantly lower risk of postpartum hemorrhage, and this was seen in the total first results and among the PRIMEP comparisons. And this is half as likely in the PRIMEP teenagers versus the PRIMEP 20-plus-year-old group. There were no real significant differences amongst fetal outcomes, and we didn't show any statistical difference in the risk of preterm birth among teenagers. As I said, the mean term birth rate is slightly lower among the teenagers, but this wasn't, I don't think, a clinical important result. So in terms of our recommendations from this study, we feel more confident giving reassurance to our teenage mothers regarding specific local pregnancy outcomes. That's not an incentive to encourage all of our teenagers to become pregnant. However, should they become pregnant and choose to continue the pregnancy, I think it's important that we don't frighten them regarding their outcomes. And we should continue to offer our teenagers tailored support through their pregnancy, birth and beyond in order to continue these positive outcomes. Thank you for listening.